Okay. Ladies and gentlemen, dear colleagues, thank you very much for being here today. We are talking today about the use of laser in proctology. Okay, so the new technology, as you know, is helping us, or is trying to help us to achieve better clinical results. And we are hoping to give patients less discomfort with our procedures. So this is the goal of the laser. We are using a diode laser, which I am now routinely used for 3 different procedures. The FILAC, which is the treatment for fistula and fistula, HELP, and the variation HELPEX, which I'm using for hemorrhoids, and then CILAC, which I'm using for the sinus, okay? So FILAC is an acronym for fistula laser closure. And this is basically based on the concept that if we introduce a laser fiber inside the fistula, we can cause a shrinkage of the fistula itself without damaging the surrounding muscles. So this is going to be a sphincter saving technique. It's minimally invasive. And with this technique, we are using a diode laser, which is set up at the wavelength of 1470 nanometers. The HELP is an acronym for hemorrhoids laser procedure and used for hemorrhoid. We are using now a laser which is acting upfront the laser fiber. And so basically this procedure is a Doppler guided hemorrhoidal dertalization with laser. We are using a 980 nanometer, and the rationale of this kind of procedures is just to close the terminal branches of the superior rectal artery. And the good thing is that we can use the laser without anesthesia. So this is going to be really minimally invasive. The third procedure is the CILAC. With this procedure, I'm treating the sinus, the palatal sinus. And this is basically the same concept of FILAC, in which we are using the fiber inside the sinus tract in order to shrink the tissue without excising big tissues around. So this is a presentation. I will be very happy to answer to your questions. Somebody is asking me which type of laser is used for the performance of the laser hemorrhoidoplasty procedure. Well, first of all, I have to tell you that with laser, I'm not doing the laser hemorrhoidoplasty, which is a bit different from the one I'm using for hemorrhoids. I'm doing the HELP procedure, which is actually not an hemorrhoidoplasty, because I am doing a dertalization. So when I do the HELP procedure for hemorrhoids, I'm using a 980 nanometer diode laser. For a laser hemorrhoidoplasty, on the contrary, you have to use a laser which is similar to the one used for the FILAC, which is a 1470 nanometer, which is acting 360 degrees. The difference is that in the first procedure, the HELP procedure, we are just closing the artery. So we want to cause a shrinkage of the terminal branches of the superior rectal artery. Whereas in laser hemorrhoidoplasty, we get the fiber inside the hemorrhoidal plexus and want to cause a shrinkage of it. So another question would be, could you give me the difference between Biolitech and Lansotronics? 2 different companies. I'm using usually a laser made by Biolitech. I do not know the other company. So I really cannot really answer to this question. Another question is, what is the indications for HELP? Again, the HELP procedure is the hemorrhoidal laser procedure, which basically is a dertalization of the hemorrhoidal arteries. So it's the same concept that was proposed by Morinaga in 1995. we are getting to, with the Doppler-guided probe, we are getting to the terminal branches of the superior rectal artery, about 2.5 centimeters above the dentate line. And once we have located the arteries, we are closing them with the laser. And because the laser is really very precise, and we are acting about 3 centimeters above the dentate line, we are not causing any pain. So the procedure, which is really incredible, can be done without anesthesia, just lubricant. If the patients have a sort of significant prolapse, so we're talking about an advanced third-degree hemorrhoids, then we can add to the laser procedure, to the HELP procedure, also a recto-anal repair, a bit of what is done with the THD procedure. So in that case, I believe we are healing the hemorrhoids, because we are actually acting against the two pathogenetic aspects of the hemorrhoids. One is the bleeding, so the vascular problem, and the other one is the prolapse. Another question regards the CLAT. Okay, so Professor De Parades is asking, do you perform CLAT under local anesthesia? Yes, absolutely. CLAT is the procedure for the pilonidal sinus. I'm doing that with just local anesthesia. And in my opinion, this is my personal experience, I think that this particular procedure is mostly indicated when we have different orifice away from the median part of the celiac. So that's the real advantage of using such a procedure, because the opposite would be to have large excision of tissue. Whereas when we are using CLAT, of course, this is just excising the little orifice and then destroying the inner epithelium of the sinus. Emmeline Field is asking me, during laser procedures, which is the most common complication that can appear during these surgeries? Okay, during the HELP procedure, which is the procedure I use for hemorrhoids, the thing that could happen is intraoperative bleeding. It is very interesting that the bleeding appears only during the operation, and this is due to the fact that sometimes the laser is not, there is not that much efficacy in that particular procedure to close the artery. So what you can do, if you see the bleeding, you just put a stitch there, like a little suture, or what I'm doing, like recently, I'm just using some rubber band ligation on the bleeding part. Regarding the FILAC, actually, it's very uncommon to have intraoperative complication during FILAC. And the same about the CLAT. But the CLAT, you can have some sort of bleeding, but just you can just press and on the tissue, and that the bleeding would stop. Zelal Al-Bded is asking, what do you do for excessive skin after hemorrhoid laser therapy? I think this question is more related to the hemorrhoidal laserplasty, which I do not have experience with, because I'm doing the HELP procedure. So, you know, this is my personal opinion, but I prefer to go on the hemorrhoidal arteries and not to use the laser inside the hemorrhoidal plexus. But this is my personal opinion. James McCallum is asking, can hemorrhoids come back after laser treatment? Well, like for all treatments, of course, you can have some recurrences there. In my experience after the HELP procedure, I had a sort of 15% recurrences on an average of 4 to 5 years after the procedure. But you can say that maybe this is a kind of big recurrence, but if you understand that the health procedure is really minimally invasive, I mean, patients do really prefer to have the chance of going back to the operating theater or to the ambulatory treatment with a recurrence instead of having a more invasive operation. Senon Moeds is asking, can we use phylac for Crohn's fistula? Of course we do. There are a few papers published in the literature showing that the phylac operation is very safe also for patients with Crohn's disease. And I think it's a very good procedure for that, because of course we can expect a lot of operations in Crohn's fistula, and so the more being really less invasive in these cases, of course it's the best. Okay. Let's see another question. How is fistula treated by laser devices? Aman Edwards. Okay, the concept of the phylac, I told that at the beginning, is to shrink the fistula around the laser fiber. And we do achieve this because we introduce the fistula fiber, the laser fiber, from the external orifice until we get to the internal orifice. Once you see with the anal dilator, you see that the tip of the fiber has reached the internal orifice, then you would start to act the laser. And once you have started to give power to the laser, then you retract the laser very slowly until it reaches back the external orifice. I use, approximately a speed of 1 millimeter per second. This should be enough to cause a shrinkage of the tissue around the fiber. Vincent de Parades is asking, how do you use the generator setting for phylac? When do you change the setting? Okay, for phylac, I use a 1470 nanometer wavelength. At this wavelength, the laser is giving an energy which is mostly causes a shrinkage of the tissue, okay? Which is different from the one used for hemorrhoids, where I'm using 980 nanometers. Now I'm using a different kind of platform for laser, and this platform, which is called Leonardo, gives us the opportunity to mix different wavelengths. So, for example, usually for phylac, I'm using an energy of 13 watt. All the 13 watt are set at 1470 nanometer. But with this new platform, I can use, for example, 10 watt of 1470 nanometer plus 4 watt of 980 nanometer. So I can combine the two different wavelengths. And this, in perspective, could give us the opportunity to add the shrinkage action of the 1470 nanometer to the coagulating effect of 980 nanometers. So this is a good thing for the future. We should try to mix the two different wavelengths. Ahmed Girat is asking, do you use pulse mode or continuous mode for hemorrhoids? And how is the energy setting? Okay, for the hemorrhoids, for the HELP procedure, in order to close the terminal branches of the superior rectal artery, I'm using a pulsed mode so that the laser does not act continuously. And I'm using, again, 980 nanometer. This is because at this wavelength, the laser is basically absorbed by the chromophores, which are inside the hemoglobin. So it's basically sort of selected kind of action of the laser. In that case, so the arteries would shrink under the action of laser. And the energy setting for health procedure is 13 watt, again at 980 nanometers. Okay, Ruggero Montalcini is asking, can you give your opinion on how was the transition from a traditional approach to minimally invasive surgery for senior surgeons? Well, I think that everybody of us, you know, I consider myself a senior surgeon now. I think we have a sort of curiosity for new technology applied to surgery. And that's what pushed me, especially, you know, to start with the laser procedure. When I started my first cases, before starting them, I worked very close with a physical engineer of the University of Padua. And we together, we started to use the laser on pig tissues, just in vitro kind of experiments. And so with my advice to him and his advice to me, we came to the real setting of all the different procedure. Because, for example, I was telling him that in order to close the arteries, the terminal branches of the superior rectal artery, we had to go with the laser to a depth of 4 millimeters, no more. Otherwise, would have been, you know, kind of it would be dangerous, you know, for the patient. And so, by my advice, again, you know, he was just getting to the real final setting. Okay, Jose Luis Tristancho is asking, have you an experience in treating complex Crohn's disease fistula combining PHYLAC with cell therapy? Actually, I don't, because my center is not a reference center for Crohn's disease. So I have treated some patients with Crohn's disease, but not so many. So I have no idea how you can combine these two therapies. But thank you for asking this question, because I am really sure that the healing after PHYLAC has to have a sort of immunological basis. So even in patients with Crohn's disease, I guess that the secret would be to give them the opportunity to heal better, because the shrinkage caused by the PHYLAC is just an initial part of the healing process. And the rest of the process has to be related to immunology and to immunotherapy. So I guess also in Crohn's disease, the cell therapy would definitely help patients treated by PHYLAC. Another question, Seinon Moetz is asking, is the use of PHYLAC always safe for sphincter? The answer is yes. Again, when we did these experiments in vitro, we realized that by using the 1470 nanometer continuous laser, diode laser action, we had an action just confined within 4 to 5 millimeters, no more. And so this is usually the caliber of the fistula. So basically, with PHYLAC, you are pretty sure you are not damaging the sphincters. And as a matter of fact, all the papers published in the literature so far are talking about basically no incontinence or very little incontinence rate after PHYLAC. Drew Harrison is asking, how do you describe the learning curve for minimal invasive surgery? Well, that's a good question. It's really difficult to answer to this question. I would say that for both L procedure and PHYLAC procedure, probably, you know, a minimal of 20 procedures are necessary just to have a sort of experience on that. But of course, as you know, we are all surgeons, so we know that we learn in each patient, we learn something more. And so my experience told me that even if we have the same conditions, the same kind of patients, one patient would heal in 4 weeks, another patient doesn't heal at all. So there should be something that we should still have to learn. Alejandro Pelle is asking, which type of instrumentation do you recommend in terms of a surgical laser device? Well, first of all, we are using, again, a diode laser, so not CO2 laser or the laser that were used in the past, so a diode laser. I think it's very interesting, the platform I'm using now, which is made by a German company, which actually gives me the opportunity to mix the different kind of wavelength, because this, I think, there should be a future with that, because one, as I told you before, if we use the 1470 nanometer diode laser, there will be more of a shrinkage of the tissue, whereas where we are using the 980 nanometers, we are causing a coagulating effect. So the combination of the two different wavelengths, could be of help. So a laser device, a laser platform, which enable us to combine the two wavelengths, could be of help. Lucia Oliveira is asking me, hello, Paolo, thank you for sharing your experience. I tried the laser in 3 cases in Rio, and one of the patients had a lot of pain after the procedure. How do you suggest someone who is starting laser, how would be the training process? Okay, Lucia, this was my experience at the beginning of my experience with PHYLAC, which is more than 10 years ago. I had a few patients with a sort of anismus postoperatively. So they told me that they had this pain, which was quite of pain. And I thought that it was due to probably a sort of over-treatment. This means that once you get your laser fiber inside the fistula tract, you don't have to stay in the same position for a few seconds. You just have to move the laser fiber within the laser tract, the fistula tract. And this is the best way of getting the shrinkage without causing maybe an overeating of the sphincter around, which could be actually the cause of this postoperative pain or anismus. So I think, the training process is quite good, and probably learning curve is about 20 cases. Angelina De La Rosa asks me, which is the main difference between laser hemorrhoidoplasty procedure and open surgical hemorrhoidectomy? Good question. Well, I told you before that I am not doing hemorrhoidoplasty procedure because this is my thought. I do not believe in this kind of procedure, because I believe that basically the hemorrhoidoplasty, which again, for those of you who are not familiar with the laser procedure, hemorrhoidoplasty means that the laser fiber is introduced directly into the hemorrhoidal plexus and causes a shrinkage of the plexus. I do not believe of this concept, of this rationale. So I'm doing HELP procedure, which is different from the hemorrhoidoplasty, and is a dearterialization, Doppler guided with laser. If I want to answer anyway to your question, I think it's a good question. Probably with the laser hemorrhoidoplasty, you don't have to excise, you cause a shrinkage of the tissue around, so you don't have to excise large part of tissue. And this is the main difference with an open surgical hemorrhoidectomy, I guess. Nicola Antonacci is asking, what kind of fistula represents the best option for PHYLAC procedure? Good question, Nicola. The best indication for PHYLAC procedure is the typical complex fistula. When I talk about complex fistula, I'm talking about a high fistula, so basically at least a transsphincteric fistula, or a multiple recurrent fistulas. In this case, you really want to have a minimally invasive procedure, and PHYLAC is a really minimally invasive procedure. Jose Luis Tristancio is asking, laser has been a talismanic word in private practice, but why hasn't it been generalized in public practice? What is your opinion? Good question, Jose Luis. I don't know. And I have to tell you, anytime I go to convention, the first question is, how much does the laser cost? I can tell you my experience. In my hospital, the laser is given free of charge. So the only thing that the hospital is paying for each patient is the laser fiber or the kit, the laser kit in case of help. And just to give you some figures, the fiber for the laser treatment of fistula, so the FILAC and the CELAC, is about, in Italy, is about 300 euros, 350 euros. And for the hemorrhoids, about 400 euros. So about $400 or $350. So it's not that expensive. So I'm not sure why the people are still kind of cautious to get into this world of laser. I can tell you that basically the laser is very easy to use, and all the techniques I'm using are repeatable. So minimal invasive, repeatable. I think, very little discomfort to patients. So why don't you use it? Not sure. Liliana Ventura is asking, is laser technology a good treatment for fissures? Actually, I never used the laser for fissures. I do not think it's indication, because usually, generally speaking, for fissures, we are doing an internal lateral sphincterotomy, so there is no way of using the laser that we are using now. Another question. Okay, still looking for the last question. The last question, do you think that the caliber of fistulous tract represent a limit to use the laser ablation? I mean, there is a cutoff in which the laser doesn't work for healing. Thank you very much, Nicola, for this question. It's going to be the last question, but it's very interesting. I think that the caliber of the fistulous tract is very important. And that's why, generally speaking, in complex fistula, I'm trying to split the operation in two different procedures. In the first procedure, I am just excising the external orifice, and then I am correcting the fistula, and I am inserting inside the fistula tract a sort of silastic drainage. 3 months later, I let the patients undergo an MRI, and if I see that the fistula is good, healed around the silastic drainage, then I will do the FILAC. This means that in that case, the fistulous tract will be 4 millimeters, which is the caliber of the silastic drainage I'm using. And that's the best way of healing the patient. So fistulous tract, very important. Well, I take the opportunity to say thank you very much for everybody for being here today. And I will be very happy to answer to your question privately on my email if you want. Thank you very much. Bye-bye.